So first I'll do a case presentation of our case, and then talk about kind of how we evaluate blunt liver injury as well as manage it, and then talk about this case with the progression of pneumobilia and hemobilia, as well as about the cost of medicine. So this patient was a 28-year-old Caucasian male. He presented as a level 1 trauma after a single motor vehicle crash with a concrete wall. He was a restrained driver. He had a negative LOC. In the field, he had a needle decompression for decreased breath sounds on the right. He was hemodynamically stable on transfer, and he arrived with a GCS of 14, and his main complaint was right upper quadrant and right-sided chest tenderness. He had minimal past medical history, no past surgical history. His physical exam was unremarkable, with the exception of some right chest tenderness, some decreased breath sounds on the right. He still had the needle decompression catheter in his right upper chest wall, and he was tender to palpation in the right upper quadrant. But otherwise, his abdomen was soft and non-distended without guarding. His labs, his hematocrit was 33, and his INR was 1.5 essentially, and he had some elevated ALT and AST, so his liver enzymes were elevated. He received a FAST exam, which was positive for fluid in the right upper and left upper quadrant. And then he also got imaging that showed some rib fractures, a right pneumothorax, as well as a liver laceration and some hemoperitoneum. So here is his first scan when he initially arrived. Okay, so now we get to the liver appearing, and you can see that this is quite a good deal of injury. This is what normal liver is supposed to look like. This is the injured portion of his liver in the right lobe. The left lobe, not as much. So, and then as you go down, you can follow the hemoperitoneum down. Okay, and then on this other view, you can see the liver injury again up here on this right side. So this was his initial presentation. So he also received x-rays of extremities and was found to have a right fibula fracture as well as a right talus fracture. So initially, we put in a 14 French pigtail catheter in the right chest, took out the needle decompression catheter. For the first 3 days, he was managed non-operatively. He developed an ileus with increasing abdominal pain and distension, was treated with an NG tube, and then was eventually, received another CT scan due to the increasing pain and distension, and was offered a diagnostic laparoscopy and abdominal washout, which was performed on the 26th. What was found was a good deal of old clotted blood, and they used about 8 liters to wash out his abdomen. Then 3 days later, he went and had his fractures fixed. On the second, chest tube was removed, and they also performed a HIDA scan that showed a biloma, and also unable to visualize the gallbladder due to the expanding hematoma that was pressing on the cystic duct. The reason this was done is he had increasing total bilirubin. It went from 1.1 to 4 on the first, and so that's why we started looking at a HIDA scan at that time. He also started having a little bit of bloody NG tube output on this day. On the third, a cholecystostomy tube was placed due to the HIDA results, as well as the T-bili, and then that began to come down once the gallbladder was able to be decompressed. The 4th through the 6th, he started having bloody stools, but he had an elevated INR of like 2. So they were holding off on ERCP and stent. GI was looking at him and evaluating him during this time, and eventually he was given FFP, and eventually he went and got an angiogram with coil embolization of his replaced right hepatic artery pseudoaneurysm. This was because the bloody stools, we were concerned for hemobilia, and that's when IR got involved. They initially went into the celiac and tried to find his right hepatic artery, but then he turned out to have a replaced right hepatic off the SMA. This is his angiogram. You can see for the medical students, this is the pseudoaneurysm right here. And then we put some coils in it to stop the bleeding. And then you see that it has stopped the pseudoaneurysm and it's successfully coiled. So on the 10th, he was able to get his ERCP. It showed a moderate biliary leak off his right hepatic duct. So he had dual 2 stents placed, one in the right hepatic duct, one in the left hepatic duct. He also had a sphincterotomy and a balloon sweep of sludge that was seen. On the 15th, he got another CT scan. He, throughout this time, was having fevers intermittently up to 102, 103, as well as, an elevated white count up into the around 34, I believe was his highest. And so he continued to receive imaging, and at this time they placed a pigtail catheter in his right upper quadrant fluid collection. And then we did a cholangiogram that also showed a patent cystic duct, but persistent bile leak, and he was discharged on the 24th to Siskin. This is his CT scan before the placement. And you'll see over here things that are developing. There's air pockets in here, so there's some pneumobilia. You can see it kind of throughout, and this is why we chose to place the pigtail catheter more. Again, that's not normal. There's not supposed to be air there. And then you can also see the coil embolization up there, as well as the stents that are coming down here. Okay, and here's another view where you can see it's starting to, you can see a lot of air there. As well as obviously it's pushing up against, pushing up his right lung there as well. And he did complain of lots of pain throughout this process. So he was discharged to Siskin, and then about 6 days later he was readmitted for dehydration for 1 day, and then he was discharged back to Siskin. On the 20th, they removed the cholecystostomy tube in office, and then on the 23rd he was readmitted for a pigtail drain placement into the fluid collection and discharged at that time. This was that scan. You can see still kind of some more loculated pockets now on here, the drain and the stents you can see as well. And so this was the CT scan from the 23rd. So it was looking a little smaller. There's your drain right there. Okay. So then I thought this was over, but then last week he comes back again, had a CT scan and an ERCP that showed a persistent bile leak and proximal stent migration. So both the stents were removed, and then a stent was put back in the right hepatic ductal system. On the 30th, we also took him back to the OR for a laparoscopic liver debridement and drain placement, a CT scan at that time as well. They went in and with a laparoscope, looked, and also used the laparoscope to view through the tract to view inside the liver cavity there, and they were able to place this Malincott drain. While they were in there, they had a good deal of purulent drainage expressed with their debridement that was fairly successful. So his is an ongoing story. We continue to take care of him after this very extensive liver injury. So when we evaluate blunt liver injury, the first thing we do in the trauma bay is obviously history and physical. We look at the mechanism of injury, how fast was he going, what kind of force was there, and what should we look at. On exam, a lot of time pain in the right upper quadrant, right chest wall, or right shoulder, and you should look for seatbelt signs, contusions, and hematomas. There's associated injuries in 80% of people with liver injury. The main one, the most common one being lower rib fractures, which he also had. These chest injuries, also spleen, as well as pelvic fractures and spinal cord injuries with that much force. We also immediately draw labs when we're in the trauma bay. There's no specific test to diagnose a liver injury. You often see an elevated white count due to the stress, but anemia is not something you should count on. It might be there, it might not. The time course is variable, and a lot of it's related to how much fluids they've gotten, how much we're giving them, as well as the just endogenous fluid shifts. But so the absence of anemia does not rule out significant bleeding, especially when they first arrive. There's no consensus on predictive value of LFTs. His were elevated. A study in 2016 actually found they looked at AST and ALT. It was in China. They were trying to decide if people with potential blunt liver injury needed a CT scan. And what they found is that elevated liver enzymes did not indicate that they had an injury. However, if they had if the enzymes were not above these values, then it was predictive that they did not have a liver injury. So it can rule it out for you, but it does not rule it in. Imaging, when we're evaluating a fast exam when they come in, and it's showing signs of liver injury, you'll see subcapsular fluid, intraperitoneal fluid, and fluid in Morrison's pouch, which is that little area between the liver and the kidney. But a negative fast exam, again, does not exclude liver injury, particularly if it's inside the liver. So they also recommend that you can do a diagnostic peritoneal aspiration or lavage if the fast exam is equivocal. This is an example. This was not his. This is an example, but it's just showing you some fluid in Morrison's pouch here between the kidney and the liver, as well as some intraperitoneal fluid. Other imaging we get, the main one we go to for hemodynamically stable patients, we take them to the CT scanner with IV contrast. This is nice because it confirms the injury. It also grades the liver injury. You can get organ-based ultrasounds and MRI, but initially when you're diagnosing it, they're of limited value. And then you can also do arteriography, especially for patients who have indications for possible embolization, so that you can manage it at that time. And speaking of the grading, the American Association for the Surgery of Trauma has a grading scale. So you'll hear it, especially as medical students will look at it and try to figure out what grade it is. So grade 1 has hematoma or laceration. It's less than 10% or less than 1 centimeter. Grade 2 is 10 to 50% surface area or a capsular tail 1 to 3 centimeters. Grade 3, a hematoma is expanding or parenchymal hematoma greater than 10 centimeters, and the laceration greater than 3. Grade 4 is only laceration, no hematoma, but it's parenchymal disruption involving 25 to 75% of a hepatic lobe. There's a right lobe, left lobe, or it can be 1 to 3 Couinard segments. Grade 5 is greater than 75% or greater than 3 segments. Or if you look at the vascular injury, it can be a juxtahepatic venous injury, which is its own difficulties. And then a grade 6 is just hepatic avulsion. So here's kind of a picture demonstration of that, how they kind of go up from 1 to 3 to greater than 3, and then this is 25 to 75%, and this being greater than 75%, and this just being avulsed here. So managing blunt liver injuries, it depends initially hemodynamic status. That's what we initially look at in the trauma bay, and so you want to look at that first. The first treatment of choice for all patients who are hemodynamically stable is non-operative management, regardless of their injury grade, is what we try to do. And non-operative management includes observation, supportive care, as well as arteriography and hepatic embolization if needed. So reviews of the National Trauma Data Bank actually found that more than 80% of patients with blunt hepatic injury can be treated non-operatively with success rates of greater than 90%. But patients who are stable but demonstrate extravasation on CT scan actually have higher failure rates. So those are people that need to be watched more closely when you have those patients come in. You can also, like I mentioned, do hepatic embolization. These are typically, we want these to do preemptively in hemodynamically stable patients who you can see active extravasation on their initial CT. It can also be used for patients who failed the non-operative management, or it can be used to manage patients who continue to bleed or rebleed after patients have had surgery. Contraindications to doing this, as obviously their hemodynamic status, but also if they have any other indication for an abdominal surgery, such as peritonitis, you're taking them back anyways for that, so you're clearly going to examine the liver injury when you're in there. Gunshot injury, which is a penetrating one, or just, if you don't think you have the correct environment. We're in a great hospital right now, but if you're in a smaller hospital that doesn't have the environment or the resources to monitor this patient and treat them if necessary, if you don't have IR available to come in, managing them that way is not really appropriate. So there's also operative management, which is obviously a lot of what we do. There's two kind of ways to deal with it. It's damage control, and there's definitive management of the bleeding. I'm not really going into operative management in this lecture that much, but this is kind of the scheme of things. If you have minor bleeding versus major bleeding, minor you can control electrocautery, argon beam, but major bleeding you're going to need to pack and resuscitate. If the bleeding's controlled, you do the damage control laparotomy, maybe you do angiography. If the bleeding's uncontrolled, you can do a Pringle maneuver to see if you can figure out where the bleeding is or is not, and then go from there. So this is kind of the generalized scheme of what we do. A lot of times just damage control and the initial presentation with packing, and then we may bring them back to the OR the next day to look and see if it's controlled or if they need something else done. So outcomes, there are rare complications for grade 1 and 2. There's small injuries, but there are a good deal of complications for grade 3, 4, and 5, 10 to 42%. Lots of times we see byelomas, abscesses, and delayed bleeding, but the mortality is 0 to 8% typically. And then this study in 2012, they looked at complications following high-grade liver injuries, high-grade meaning 3, 4, and 5. They found increased complications seen in patients who had operative intervention, as well as patients who got angioembolization versus non-operative management. In managing this, it's recommended to get a repeat CT scan at 7 to 10 days, or if there's any clinical signs and symptoms of complications, right upper quadrant pain, jaundice, fever, melena, our patient had right upper quadrant pain. He had his T-billy increasing. He was having intermittent fevers as well as elevated white counts, and he also developed bleeding as well. He, as you saw, was pretty impressive, the pneumobilia, the air within the hepatobiliary system. There are many causes for this. Our cause for ours was liver abscess. And then the main talk I want to talk about was hemobilia and upper GI bleeding. So it's a very common problem. This is a commonly worked up problem. And one thing we see a lot is with our ICU patients. There's overt GI bleeding in like 1.5 to 8.5%, but it can be as high as 15% without stress ulcer prophylaxis. That's why a lot of our patients, especially our trauma patients, go on GI prophylaxis with a proton pump inhibitor a lot of times. There's different reasons for upper GI bleeding: ulcerative, erosive, portal hypertension, traumatic, vascular lesions or tumors. Most commonly, we see it in ulcers as well as gastritis, esophagitis. But the less common causes, and the one that I'm going to talk about, is actually the hemobilia. Hemobilia is it's bleeding from the hepatobiliary tract, and it's a rare cause of upper GI bleeding. This happens when there's a fistula between a blood vessel and the biliary tree. It's most commonly arterial, less commonly venous, just due to the lower pressure in the venous system than the biliary interluminal pressure. So most often it is an arterial connection. There's a variable time interval to the development of hemobilia. It can happen anywhere from the initial injury up to, it's been reported, to 120 days. The late presentation is actually due to delayed healing and necrosis of the cavity, as well as erosion of adjacent structures, and that's what causes the hemobilia or a pseudoaneurysm formation. So the main cause is actually iatrogenic trauma, so that would be ERCP, stent, or percutaneous liver procedures, and that's about 50% of cases. Accidental trauma is next in line, so like we're talking about blunt liver injury, but hemobilia is actually only seen in less than 3% of liver trauma cases. Other things that can cause it: gallstones with mucosal erosion, inflammation, ascariasis, so we don't have a whole lot of worms here, but abscesses and vascular conditions such as a hepatic artery aneurysm. And of note, the severity of hemobilia does not correlate with the grade of liver injury, so you can have a severe amount of bleeding with an arterial connection that is in a grade 3 when you would expect it more in a 5. They're actually not correlated to their grade. One of the signs and symptoms that they're going to tell you in the textbook for medical students, there's a Quincke's triad of hemobilia. It's only present in 22 to 30% of patients. But they have abdominal pain, they have biliary colic, they have obstructive jaundice, and they have occult or acute GI bleeding. So to evaluate these patients, the current modality of choice is a contrast-enhanced CT scan of the abdomen, and it's in hemodynamically stable patients. You can also get an EGD where you visualize, this is helpful because you can visualize clots. You can also identify other sources of bleeding if that's not actually what it is, because you're looking in there. But you only visualize bleeding in 12 to 40% of cases. Angiography is very helpful. This can give you a definitive diagnosis, and you can treat it immediately. So if you're, typically you start with the CT scan and then, as needed, the angiography. Initial management, though, is just resuscitation and controlling sepsis, especially if you've got an abscess. And there are two principles in managing hemobilia. First, you want to control the hemorrhage. There's several ways you can do that. We did transarterial embolization. That's what we did. You can do arterial stenting or thrombin injections. And you can also do surgery. You can ligate the bleeding vessel. You can excise the pseudoaneurysm. You can do a partial hepatic resection, explore the common bile duct. And the other principle is biliary patency. You want the bile ducts to be open. Bile needs to be able to flow out. So doing an endoscopy with a sphincterotomy, which was done, removing blood clots, or inserting a biliary stent, which is also done. So looking at this systematic review, in 2011, they looked at outcomes for embolization because we kind of use it loosely and even include it in the non-operative management, but it is, still a procedure that's done on our patients. And it looked at transpapillary hemorrhage, so hemobilia in combination with hemosuccus pancreaticus, so bleeding from the pancreatic duct. And it showed technical and clinical success rates being very high, in the high 80s and low 90s, and rebleeding rates of 9% and only a complication rate of 5%. So this was actually very successful in treating transpapillary hemorrhage. And then the thing I wanted to look at kind of in all of this is cost of medicine, a CT scan, because that's the modality we use all the time. And it's approximately $3,200 for one CT scan with IV contrast, which, our patient had several CT scans to monitor, but kind of necessary in the treatment of this condition. And so are there time for any questions? These are my two cats, Tinkerbell. I just found Pepe under the bridge recently.
Thank you very much for that. We'll open the floor for any discussions. I noticed that, as a non-trauma observer, that liver looked pretty bad, and the first thing that came to my mind was how often does liver transplant ever come into play with such severe liver injury? Bob, you want to help us?
To answer your question, I've never heard of someone getting a liver transplant for hepatic trauma. I'm not saying that hasn't happened. You'd virtually have to have a liver coming out of somebody when somebody came in. I guess down the road there could be indications for that if you develop some kind of severe complication. Nice presentation. Kind of felt like I was watching a Charlie Chaplin movie, but the thing I'd highlight about this case is when you have a grade 4 injury like this, particularly if it undergoes hepatic embolization, that you're going to have a big mass of necrotic liver, and it's hard to manage that non-operatively or with percutaneous drains. At some point, you have to go in and just shell out the dead liver because this otherwise will go on for months and months. And patients, smoldering sepsis from something like that. So that's something that you need to plan on. You need to counsel the patient and the family about that. Just so they're aware that this isn't something you just wave a magic wand over with embolization and it's all going to be better again. From a service line perspective, you did a very nice job, presenting the time course of this, but I think this guy got transferred out of the unit twice and had to go back from rebleeding because you couldn't see that pseudoaneurysm on his CAT scan. And when we reviewed this in our quality improvement function, we're working on an algorithm now that will at least list the option of arteriogram for everybody with a grade 4 injury because you could not see the blush on this guy. So from a quality improvement standpoint, a filter kicked this patient out for bouncing back to the unit twice because of this occult bleeding from the hemobilia.
I had a question for you. So typical board question, what vessels to the liver may you ligate? Can you ligate the portal vein, the common hepatic, right hepatic, left hepatic? That comes up. That's a great oral question. Do you
Great question.
know which ones you may ligate?
I know you can do the right hepatic. I don't know the rest of those, though. I don't know the answer to that.
Okay, I don't think you can ligate the portal vein, number
No,
one.
I don't think you can.
And probably can ligate the common hepatic. I don't know about the others you probably get by with it right. Anybody want to answer the question? Who's the chief over here?
Take it on your algorithm. There was something down there called SHAL, and that would be
Selective hepatic and
arterial
arterial
ligation.
ligation.
So I made the mistake of opening my mouth, but typically you can't ligate the portal. You can ligate the common hepatic. You cannot ligate the proper hepatic. that also depends if your GDA is intact or not, or if you have any replaced vessels. So it gets a little complicated, but don't ligate the portal vein is probably the biggest take home.
So I'd make 2 quick points. I completely agree with what Bob says. You know, I had to basically argue with the radiologist to get them to angio this guy because they said he has a CT scan that doesn't show anything. And I told him, I said, he's got hemobilia. I promise you he's got something. There's no other reason a guy like this bleeds this much. A young guy, if he's got an EGD with no ulcer, no anything else, with liver trauma like that, that's what it is. And then secondly, how do you follow patients? Let's say you have a patient with a grade 3 or 4 liver. They come in the hospital. They don't have necessarily the course this guy has, and 7 days later they go home and they see you in the office in 3 weeks, and they say, I'm doing well. Grade 4 liver injury, I'm doing well. Do they get a CT scan at that point?
The recommendation I saw was 7 to 10 days a repeat CT scan, or if they develop signs or symptoms. So at 3 weeks, I don't necessarily think that's necessary since.
So everybody with a liver trauma is going to get a CT scan at 7 to 10 days? The reason I ask this is because, I mean, and I don't argue on this guy. I think he had clinical indicators that made you do this, but I mean, this is a very young patient that now has had, I don't know how many CT scans, probably 10 CT scans.
14.
14 CT scans in a 2-month time period. But I'm just saying, I'm asking the question of what are we going to recommend to patients as far as serial CT scans?
I mean, I think if they're stable, they're not having any signs of it, because you don't do it with a grade 1 or 2. Only the higher grade you would consider doing a repeat CT scan. I don't think if they're having problems that they necessarily need it.
I think the longitudinal follow-up for liver trauma is that you basically base it on their symptoms. And if they come in with fullness in the right upper quadrant, certainly bleeding, hyperbilirubinemia, those are indications for get a CT scan. Otherwise, they don't get a CT scan.
I've been trying to push CT scans out on this guy as long as possible.
Oh.
I think you all know his family,
Yes, I
who
do.
um,
Threatened to.
calls me every day. Basically, every single day I get a phone call. And, they're very aggressive about pushing for CTs as every 3 days. But I'm trying to push them out as far as possible. I'm hoping that this drain that's in now will develop enough of a tract to let the rest of this out. We were able to put a scope into the cavity, and there really didn't seem to be that much necrotic liver there, and we got some necrotic liver, probably the bulk of the necrotic liver out through this approach. So I'm hoping this is the last hurrah on this guy. We did have a scope in the abdomen as well, just to make sure that we didn't violate the peritoneal cavity with this stuff, and that we just needed to open and marsupialize that whole area. But
Bob, you want to comment again? You were looking around.
I didn't understand from the original description what you did operatively. So when you took him to the operating room, you just put a scope through the drain tract, through the ribs, and into the cavity, and you didn't explore this transabdominally?
no, I did not explore it transabdominally. I had a scope in the abdomen so that if I were to violate that cavity, I would know I had spillage into the peritoneal cavity to wash that out. But we went through the drain tract, opened that up, put a wound protractor in there, and were able to get a scope into the cavity and wash all that out and kind of debride the portions of necrotic liver.
Yeah, that's an interesting approach. I haven't heard of that done before. It looks like it's going to work. Traditionally, I've broken the rind open on those things and debrided it laparoscopically, and then put some momentum up there and get the momentum to heal on top of the liver and seal the bile leak up. If that works, that probably is a case report.
I mean, it's sort of treated it similar to a VARS to see if this will work. I mean, again, his family wants to avoid any type of open surgery if they can. And he's clinically doing fine. I mean, he's eating, his nutrition's better, he's gaining weight, occasional fevers, but those have pretty much subsided since we've done this. And My plan was to see what things look like on Friday. There's really no, like if you look at it with a scope, there is no externally obviously abnormal liver. So I'm going to have to go through normal liver to get into this this cavity to marsupialize this out if I open them.
I think as long as you got the big chunks of liver out of there, it'll eventually obliterate that space, but he's just missing a big chunk of liver that has to, scar in and contract.
I had a question, liver injury that bad and you have to put biliary stents up, do you almost guarantee yourself some kind of biliary organism infection? Pretty much, so you should expect that. We're going to go ahead and move on to the next one here. I would tell you that your chairman's on a plane right now heading to California to the Halstead Society. Dr. Ken Sharp, many of you know him from Vanderbilt, had requested he be there because he's president this year. So that's where Dr. Burns is at the moment.
Morning, I'm Brent Moss for the medical students I haven't met yet. I'm a second-year resident. I'll be presenting an interesting case titled Heterotopic Ossification, a Rare Cause of Traumatic Bowel Perforation. I'd like to thank Dr. Dart and Dr. Kestner for allowing me to participate in the case. Outline of the talk today is going to be a patient presentation, overview of the topic of heterotopic ossification, a review of the literature. We'll go over several case reports, and then conclusion. So our patient was a 92-year-old male who presented to the ED with abdominal pain. He was seen 1 day prior after being involved in a motor vehicle accident. He was worked up by the ED at that time and was ultimately discharged by them after a repair of his scalp laceration. He then represented 1 day later after his accidents with diffuse abdominal pain and altered mental status. It was reported that his abdomen had hit the steering wheel during his accident the previous day. Most of the rest of his history was taken by chart review because of his altered mental status, but through EPIC we were able to find he had a history of cardiac arrhythmias, hematuria, hypertension, and type 2 diabetes. He had an unknown past surgical history, but through some deductive reasoning, he had a midline of laparotomy scar and previous CT scans that revealed a partial colectomy. His medications, allergies, and family history were all unknown. As far as vital signs, his heart rate was hovering around 98 to 105. His blood pressure was in the 110s, and his respiratory rate was 26 breaths per minute. He was in obvious distress upon our physical exam. He was alert but oriented only to himself. His abdomen was obese, it was tense, it was distended, and it was peritonitic. ISTAT labs at that time were sodium 146, potassium of 3.7, a notable creatinine of 4.2, and a lactate of 5. So he was taken to the CT scanner. This was the scout picture here. He had a CT non-con, and I'll draw your attention to this upper portion here. As we continue to go down, you see into the sternum xiphoid, and then another ossified structure here that continues down almost all the way to his umbilicus. And if I'll go back up as well, he also has free air as well, but this ossified structure appears fractured right here. We'll look at another view as well. So here's another view that I think is a better representation, maybe easier to see. End of his sternum here, and then this ossified structure all the way down from pretty much xiphoid down to his pubis with a fractured here, and then free air all along in his mesentery and his abdomen. So here's just a couple still shots from earlier. So this is the fractured part with free air, and then the other view, same thing, the fractured with this ossified structure in free air. So he was taken to the operating room. A midline incision was made along the patient's prior incision. The incision was carried down to what appeared to be this ossified structure. It was retracted to the side, and bovie electric artery was used to dissect further down to the peritoneum. The abdomen was then bluntly entered, and there was noted to be dense adhesions all along his previous incision and this ossification as well. Upon lysing these adhesions, there's noted to be a large amount of succus in the patient's abdomen. As we lysed going cephalad towards the superior part of the incision, it was discovered that this fractured part, this ossified structure, had fractured and then penetrated his small bowel. This portion of the small bowel was removed, and a side-to-side anastomosis was performed. We then irrigated his abdominal cavity and then removed the remaining portions of this ossification. We got out a total of 4 segments ranging from 2 centimeters long to 8 centimeters long, using blunt dissection and bone cutters to get this portion out. He was closed and taken to the intensive care unit in guarded condition. The pathology came back on this several days later as trabecular bone with unremarkable marrow. This is, we don't have any intraoperative pictures, unfortunately, but this is similar to what we encountered, being this midline incision and this ossified structure along the midline there. So, heterotopic ossification is the formation of bone and tissues that do not normally ossify. Myositis ossificans traumatica is a formation of heterotopic bone after surgery or trauma, and heterotopic ossification in abdominal scars is considered a subset of this. Some characteristics of this heterotopic ossification usually occurs in men over women of a ratio of 10 to 1. There's a wide age range. It's not age related. There's been case reports from 6 years old to 87 years old, and most of the data out there, they typically occur in vertical midline incisions. As far as pathophysiology, there's 3 theories in the literature out there of why this occurs. The first theory is that small particles from the periosteum of the xiphoid or the pubic symphysis are inoculated during surgery into the abdominal wound, and this subsequently leads to the formation of bone. A second theory is that formation is secondary to immature pluripotent mesenchymal cells that differentiate into osteoblasts and chondroblasts as a result of trauma. And the third theory is that the heterotopic ossification occurs secondary to excessive suture line tension in these incisional scars. Most of the literature regarding heterotopic ossification is related to orthopedics and their bone and joint cases. The first case of heterotopic ossification occurring in midline abdominal scars was reported in 1901 as a case report. There's a good case series published in 1997 documenting a total of 79 primary cases of heterotopic ossification in midline abdominal scars at that time. Since then, there's been several other case reports and case series published on the topic. However, heterotopic ossification causing bowel trauma has proven to be exceedingly rare. And so next I'll go over several case reports that I found in the literature regarding bowel injury and fracture of this heterotopic ossification. So this first case report was published in 1997 out of Miami, titled Penetrating Trauma Secondary to Heterotopic Ossification in a Laparotomy Scar. Their patient was a 45-year-old alcoholic who presented to the ED complaining of abdominal pain. He had suffered a fall in his home after a drinking binge. He had a significant past surgical history for an operation for repair of a bleeding Mallory Rice tear. He had a CT abdomen pelvis that that time for concerns of pancreatitis due to his alcohol history. This was a figure in their case report showing this ossified structure here, and in this case they had a calcification growing into the abdominal cavity with a projection seen here. They go on to say that they, under their laparotomy, re-examination of their previous laparotomy scar revealed calcification of the abdominal wall, excuse me, of the previous midline incision, and approximately 4 centimeter wide, extending from the pubis extending from the xiphoid down near to the pubis. One of these projections, as we saw on the previous slide, was found to be growing into the omentum and tapered into a sharp point, which led to the bowel penetration upon his fall. And they go on to say that consideration should be given for elective removal of such ossifications that are symptomatic, or when the morphology, such as the ossification, poses a threat of injury to the viscera, such as in this case. A second case report published in 2003 titled Postoperative Bowel Perforation Due to Heterotopic Ossification. Their patient was an 84-year-old man who presented for elective colostomy reversal. He underwent the reversal, and then on post-op day 6, he was noted to have succus draining from the inferior portion of his wound, and he was taken back to the operating room for exploration. At that time, an enterotomy was identified that was draining succus. It was oversewn in 2 layers. They noted that he had a hard 3 millimeter by 1 centimeter irregular shaped lesion with a sharp point at the inferior portion of his midline wound adjacent to the enterotomy. They had some intraoperative pictures here, which I think was what they were describing. And then they also found another ossified structure at the superior portion of the previous incision as well. This was, I believe, a pre-op X-ray and CT scan that they obtained showing this ossified structure there. They report that their case is the first and only case of intestinal perforation from heterotopic ossification in the immediate postoperative setting. They also note that preoperative evaluation of imaging of patients that have had previous operations to not only focus on the intra-abdominal pathology, but also the possibility of heterotopic ossification in a previously operated wound. They also state that keeping an open mind when needing to reoperate in the immediate postoperative period will allow one to think of rare and remote possibilities. This third case report was out of the Air Force Base in Mississippi, published in 2011, titled Fracture of Heterotopic Bone in a Midline Abdominal Wound. Their patient was a 51-year-old male who had an open Nissen fundoplication. He presented back to them 5 months postoperatively complaining of epigastric pain. His physical exam revealed a large ventral hernia and a hard mobile mass 2 to 3 centimeters below the xiphoid within his midline scar. The mass was tender to palpation, and per the patient, it felt like 2 pieces of bone were rubbing together. They also obtained a CT scan, which they note here. And his symptoms were apparently related to the fracture of this mass and these bones rubbing together, and they became intolerable to the patient. 11 months after his initial operation, the upper end of his midline incision was explored, and a dense scar with a 6 by 2 by 1 calcified mass was excised. They noted that there is a fracture of the bony mass at the upper portion of this ossification. The peritoneal cavity was never entered during their procedure, and signs and symptoms related to this mass disappeared, and the patient had no complaints at his 6-month postoperative visit. The last case report that I found, and the most recently published in 2020, 16 out of the Netherlands. They had a 53-year-old patient presented to an outpatient clinic with complaints of a solid mass in his upper abdomen. He had a past surgical history of a post-traumatic laparotomy 25 years ago. The patient had recently deliberately lost 20 pounds and noticed a mechanical obstruction with movement and pain under his abdomen while bending forward. A physical exam revealed an easily palpated longitudinal structure directly under his previous laparotomy scar that appeared to move and articulate just below the xiphoid. This was their preoperative x-ray, which you can see here, a good picture of this ossified structure here, and they have a good intraoperative picture here of this lesion removed. And so they performed a 25 centimeter laparotomy incision from the xiphoid down to the umbilicus using the previous scar. Obviously, an irregular shaped bony calcification, approximately 3 by 18 centimeters, was removed in whole. And according to their review of the literature, the majority of the cases that they have found have been asymptomatic, and they recommend only surgical removal if they're symptomatic. So going back to our case is the first reported incidence of traumatic fracture of the heterotopic ossification causing penetrating injury resulting in bowel perforation. Thorough review of the CT images and a high clinical suspicion are key for preoperative diagnosis. And going back to the first case report, I think perhaps prophylactic removal in some asymptomatic cases may be warranted. Our patient received Zosyn in the perioperative setting. I know we have a lot of patients on Zosyn. The cost is $985 for 3.375 grams and $1,230 for 4.5 grams. And references, I'll be happy to take any questions.
Well, how many surgeons in the room run across that? Yeah, I think if you live long enough and open enough of these things up, you come across it. Some of them are quite impressive. Bob?
Yeah, I've never had one that caused a bowel perforation. That's pretty interesting. We used to see it frequently in the era of planned ventral hernias. Before the massive resuscitation protocol came along, we had everybody with these edematous bowels that couldn't get their abdomen closed during their primary hospitalization. We'd let their abdominal wound granulate in and put a skin graft on them, vicral mesh, and that seemed to be like a real nidus for triggering this hypertrophic ossification. And you just had to be aware of it. I used to have a bunch of slides until my folder got deleted of all the wound bone that we used to take out, because it was kind of humorous to see how big and problematic the bone would be. The only comment I have about your presentations was the second one. I don't know that I would want that boast to be the first to report a postoperative perforation of the bowel. I think if you see hypertrophic ossification in your scar while you're doing a laparotomy, you ought to take it out. And to not identify that, I think Helen Keller could find most of these, so I don't know why they didn't remove the bone in the first place. And my question for you would be, why did you give this guy Zosyn and not a less broad spectrum antibiotic?
I don't have a clear answer for that.
So this is one of my preachings. The real spectrum advantage that Zosyn gives you over a drug like Unison is Pseudomonas and ESBLs and resistant organisms. And most likely somebody coming in off the street with a bowel perforation is not going to have some resistant bug, and Unison should be good enough for a case like that.
Yes, sir.
Weren't there some drugs that are associated with heterotopic ossification? Wasn't nonsteroidals for a while? The ortho guys were hesitant to use it or something. Anybody got any information on that? You found no
I didn't see any
drugs?
literature on any kind of drugs that would precipitate.
Okay. Any other?
So I don't know what causes this. Obviously, there's 3 or 4 different theories, but the one I would go with is, and I try to avoid getting all the way up to the xiphoid, because it does seem like a lot of these come right down off the xiphoid from midline laparotomies. And I suspect it's just that you basically seed the soft tissue with something that then just grows. But Bob's right. I mean, I've taken out a bunch of these things, and sometimes they look like, I mean, it's crazy what they grow into. I mean, it'll be like somebody's tibia on their abdomen or something.
Yeah, I was going to say, most of the ones I've seen have all come from sternotomy patients. That's frequently you see it. But I had one patient did a femoral endarterectomy, had to go back and do a fem on that guy. He'd calcified his wound. To expose his femoral artery, had to have bone rongeurs. I mean, it's impressive. I don't ever want to operate on that guy again, but it happens in weird places, and sometimes I've had it once in the femoral artery.
All righty, we thank you for your presentations today, and we'll go ahead and move on.